Hello, everyone, and welcome. We'll just give it a couple of minutes and allow people to join, and then we'll go ahead and get started. Hello again, everyone. We'll just give it another minute, and then we'll start our webinar. Hello, everyone. Good morning, good afternoon, and good evening, and welcome to the second of our four-part Amplify Project's Global Dissemination webinar series. My name is Eva Lathrop. To introduce myself, I'm the Senior Director for Reproductive, Maternal, Newborn, and Child Health at JPIGO, where I lead our broad portfolio of work in RMNCH across over 30 countries. In this role, I provide clinical expertise in support of the Accelerating Measurable Progress and Leveraging Investments for Postpartum Hemorrhage Impact Project, or AMPLI-PPHI. I'm an obstetrician gynecologist by training with over 25 years as an educator, researcher, and public health practitioner, working in diverse global settings while continuing to provide clinical care at home. It's my pleasure to be chairing today's webinar, Transforming Global Guidance into Real Care: Essential Lessons from Frontline Providers for Implementing Postpartum Hemorrhage Guidelines for Prevention, Detection, and Treatment with Quality and Confidence. Have you ever asked yourself, how do global guidelines translate into high-quality, life-saving care consistently for everyone? During today's webinar, we hope to answer that question by exploring how global guidelines on postpartum hemorrhage prevention, detection, and treatment are translated into routine facility practice in diverse settings. Grounded in WHO guidance and real-world implementation experience from the AMPLI-PPHI project across 6 countries, this session goes beyond protocols and products to unpack what it truly takes to achieve sustained, high-quality postpartum hemorrhage care. In the question and answer session of our first webinar, Catalyzing Learning and Shaping the Global Trajectory of Postpartum Hemorrhage, there were many questions about the how of introducing new products and supporting facilities and providers to incorporate the products alongside postpartum hemorrhage guidelines into high-quality, sustainable practice. We did not get to answer all of those, but we hope to answer some of them now. Today's session will be approximately 90 minutes in length. We have 5 presentations delivered by our distinguished speakers, followed by a Q&A session and closing remarks. Before we begin, I'll take you through a couple quick housekeeping notes. If you have any questions, please click the Q&A icon at the bottom of your screen and submit them there. If you're unable to see the Q&A icon, please select the More box with the 3 dots at the bottom of your screen and then select Q&A. The box will appear for you to submit your questions. If your question is directed at a particular speaker, please make that clear when you're submitting the question. All presentations today will be in English with simultaneous interpretation in French. Please select the interpretation icon in the bottom corner to listen to your preferred language. If you cannot see the icon, select the More box again with the 3 dots and select Interpretation there. And finally, closed caption are also available today. To enable this, select Show Captions, turn on Translation, and select your caption language. If you can't see this icon, go to the More box. Our first speaker today is Miss Elaine Roman. Elaine is the Global Project Director for the AMPLI-PPHI project at JPIGO. For the last 20 plus years, Elaine has worked with global stakeholders and partners across low and middle income countries to help support country efforts to advance maternal and newborn health outcomes. She has authored several publications on malaria and pregnancy, and more recently, postpartum hemorrhage. Elaine has lived and worked in Kenya, Somalia, and Turkey, and provided both technical and programmatic support focusing on improving maternal health outcomes in nearly 20 countries across sub-Saharan Africa and Southeast Asia. She will ground our webinar today with a brief overview of the AMPLI-PPHI project. Over to you, Elaine.
Thank you, Eva, and welcome to everyone, wherever you are joining from. I'm delighted to be here today for the second webinar in our series. Up front, I want to thank our donor Unitaid, and with complimentary support from the European Union's Safe Birth Africa initiative, a joint Unitaid UNFPA venture and a Global Gateway flagship project. I also want to thank our government partners in ministries of health who have driven AMPLI-PPHI from the start, building on many years of country leadership to advance maternal health outcomes. As Eva just mentioned, I have a few slides about AMPLI-PPHI to get us started. AMPLI-PPHI was launched on the heels of decades-long work, commitment, and progress across countries, and grounded in the research and global guidance that newer postpartum hemorrhage products will make a significant difference in maternal health outcomes. Across different contexts and at all levels of the health systems, AMPLI-PPHI set out to support countries to catalyze the early adoption and scale-up of these products to prevent, detect, and treat postpartum hemorrhage. We wanted to demonstrate in real-life settings that the products shown here can be used effectively when they are available and systems are ready and providers are equipped and supported. Our project launched in August 2022 in focused geographic areas of the DRC, Guinea, India, and Kenya, with Nigeria and Zambia joining in mid-2024. Our work together with our partners, FIGO and PATH, focused on 3 interconnected priorities: generating evidence that would inform scale-up, strengthening enabling environments so countries can sustain progress, and increasing the availability of affordable, quality postpartum hemorrhage commodities. This slide highlights the reach of AMPLI-PPHI across the 6 countries and in more than 200 health facilities. These products were introduced at different times over about 30 months, and the picture is clear. Among the thousands of births across project sites, nearly all women received heat-stable carbetocin to prevent postpartum hemorrhage. A calibrated drape was used to detect postpartum hemorrhage, and among women diagnosed with PPH, they were given tranexamic acid as part of the motive bundle. As Eva said earlier, our full webinar series brings together 4 years of learning, focusing on the practical approaches that can be integrated across different contexts and into existing maternal health systems so that countries can move from product introduction to scale. This conversation is more important than ever in a world reality where funding opportunities are fewer, and as we know, women continue to die needlessly from severe bleeding after birth. The design in order of our series is intentional, and I hope you were able to join our first webinar that focused on the IJGO Amplify supplement. And as we heard moments ago, today we are focusing on the provider experience across countries and in different contexts. Webinars 3 and 4 will focus on the systems and access to products respectively. I hope that you can register for each of these. Thank you. Eva, back to you.
Thanks, Elaine. Thank you so much for setting the stage and then giving people a picture, a snapshot of the whole series to come. Our next speaker is Dr. Chikwefu Ngambi, the country program manager for AMPLI-PPHI Zambia. He's an accomplished obstetrician gynecologist with 13 years of dedicated service in the public health sector, specializing in maternal and newborn health. For the past 4 years, Chikwefu has worked at JPIGO, providing critical technical support to the Ministry of Health in the development of essential policy documents. As an active clinician, he remains deeply committed to direct patient care with a specific clinical and research focus on the prevention and management of postpartum hemorrhage. Having witnessed the profound impact of this condition on families and healthcare providers, Chikwefu is a passionate advocate for implementing evidence-based, life-saving interventions to reduce maternal mortality and improve health outcomes in resource-limited settings. He'll talk with us today about scaling prevention, bringing heat-stable carbetocin into routine postpartum hemorrhage care. Over to you, Chikwefu.
Thank you, Eva. Good morning, good afternoon, and good evening, everyone. We will be looking at how to scale PPH prevention by bringing heat-stable carbetocin into routine care. So, heat-stable carbetocin is a long-acting, stable oxytocin analog that does not require cold chain. It can be stored at temperatures up to 30 degrees Celsius over long periods of time without losing its effectiveness. It has been recommended by WHO for prevention of PPH in settings where the quality of oxytocin cannot be guaranteed. This could be due to manufacturing errors or cold chain challenges. So how do we go about introducing HSC to facilities? We have to start by setting the stage. This will require having the right tools, the tools being, firstly, an understanding of the country context. What's the maternal mortality ratio? What are the main contributors to the maternal mortality ratio? How are the cold chain systems? And what are the supply chain realities? Secondly, referring to evidence that is there on the use of heat-stable carbetocin, such as the Champion trial and the learnings from the AMPLI-PPHI project. We then use these tools in our engagement with stakeholders at all levels of the healthcare system, that is decision makers, regulatory authorities, supply chain procurement agencies, and critical to this, the midwives and the communities they serve. Considering different countries at different levels of registration, essential medicines listing, and guidelines, the engagement would have to be all-encompassing to bring all the key pieces together, ensuring that everyone is moving as one unit. Then advocacy, where we would start by identifying champions from these stakeholders, with professional associations being key, the midwives, the obstetricians, then identifying platforms such as technical working groups and strategically engaging key decision makers. Also, in readiness for facility introduction, 3 key steps are required. The first is to adopt or adapt the training package. In this case, we are referring to the Helping Mothers Survive Bleeding After Birth Complete training package. And though different countries have different structures, the training will typically start from the national level trainers to the sub-national trainers that would then cascade the training on-site at facility level. A key step is identifying peer practice coordinators at the facilities, a dedicated and self-driven person that can implement a low-dose, high-frequency training to all cadres conducting deliveries at facility level, ensuring capacity building is continuous and all new staff are trained. We then need to adapt data collection tools to capture service delivery data, as well as supply chain data for the purpose of monitoring the program, accurate forecasting, and quantification of heat-stable carbetocin. And then, of course, we need to have heat-stable carbetocin in the health facilities for the providers to utilize and be comfortable with its use. What we have seen from this approach is that there's a high utilization of heat-stable carbetocin for PPH prevention. There can be initial reluctance or fear in using heat-stable carbetocin, but hesitation quickly diminishes as its effectiveness is observed. The adoption, as expected, varied by country. As you can see, in country 2, in the middle there on the top, we started with low utilization at 37% in the first month and increased to 95% by the second month, while other countries had a more gradual increase over a few months. And what we also see is that the high utilization rates were then sustained over time. A few quotes from healthcare providers are shown, with one saying, "Earlier, we had to refer quite often, but since HSC came, we haven't referred a single case. This feels really good to us." This is just one example of the appreciation that healthcare providers have on the effectiveness of heat-stable carbetocin. The table that you are seeing in front of you shows the top 3 factors that influence healthcare provider choice on the uterotonic to use. Across 6 countries, 3 things were critical in improving uterotonic use at different levels of the healthcare system. 1, provider training, which was reinforced through the low-dose, high-frequency approach. Secondly, access to updated national guidelines. And third, the availability of uterotonics. Other factors also included not only having national guidelines, but local facility guidelines and previous positive outcomes from the use of the uterotonics. So the key takeaways from the implementation are that understanding the knowledge gap and country context is the first step. as countries will differ. Creating awareness on the use of heat-stable carbetocin with stakeholders at all levels. No one should be left behind. Securing buy-in from professional associations, the midwives, doctors, clinicians, nurses. They provide the technical support to the healthcare providers. Then updating policy documents, clinical guidelines, and training packages. This boosts provider confidence to implement. Of course, the low dose, high frequency, on-site capacity building through peer practice coordinators is critical for confidence building, skills retention, and addressing attrition. And then lastly, strengthening data management for service delivery and supply chain, as this is key to ensuring accurate monitoring. Thank you, Eva.
Thank you so much, Chikwefu. I love hearing this presentation and the reminder that for any introduction, in this case, talking about heat-stable carbetocin, setting the stage, understanding the context, making sure that all stakeholders are together, and that's a wide range of groups and people, that the tools are there, that there's an advocacy component, and that competency is sustained throughout can really make a difference. Thank you so much for this great presentation. It's my pleasure now to introduce our next speaker, Dr. Nuruddin Mohammed. Dr. Noura is a seasoned public health professional with over 25 years of experience in obstetrics and gynecology. He currently serves as the Kebbi State Maternal and Perinatal Death Surveillance and Response and Quality of Care focal person, where he plays a key role in strengthening maternal newborn health services. Dr. Noura is also the chief of the Medical Advisory Committee at Calgo Medical Center in Kebbi State. In addition, he facilitated the development of the standard operating procedures for locally fabricated incinerators, contributing to improved healthcare waste management practices, which you'll hear about today. He has been instrumental in supporting the AMPLI-PPHI project, serving as a master trainer and clinical mentor. Dr. Noura will present Every Drop Counts, introducing calibrated drapes for objective blood loss measurement and early postpartum hemorrhage detection in 6 countries. Dr. Noura, please proceed.
So thank you, everyone. Good morning, good afternoon, and good evening to all. Just like Eva has rightly said, I'll take us through the introduction of the calibrated drape for objective blood loss measurement and earlier postpartum hemorrhage detection in 6 countries. And also, as he has rightly said, I will take us through the how we were able to introduce the calibrated drapes and know what we have done already. So what is the calibrated drape? A calibrated drape is a low-cost blood loss measurement tool which will collect blood in the calibrated funnel. As you can see on the right side of the screen, you can see the funnel where the blood collects during delivery. And then you can see the yellow line, which indicates a warning line of about 300 mils, while the action line is the red line when it reaches 500 mils, for which the bundle will be cascaded. So how do we introduce this calibrated drapes? Of course, it's a government-led and context-adapted strategy in 6 countries that were mentioned earlier on. And of course, just like for the introduction of the heat-stable carbetocin, it has to be government-led and policy-backed. So for sustainability and also acceptance. So you have to involve and include the policy makers early in all the decisions for scale up of the calibrated rates. And then the product selection is also by the Ministry of Health. They give the specifications. And then for sustainability purposes, in-country vendors are utilized for the procurement of the calibrated drip. Then for sustaining the education and also the competency, a low dose high frequency practice or approach was applied using also peer mentors, using drills to sustain the skills learned for the scale up. Then the supply chain and data was also embedded in the Ministry of Health systems, the health information management systems, and also their procurement system. Then as a way of commitment for Nigeria, the slogan is one woman in labor, one drip. And then for Zambia, they included and added the calibrated drips in their essential medicine list. So these are some of the things that we've learned from this scale up, that skills were really built and retained. As I've mentioned, the low dose high frequency training and then the peer mentors were instrumental in sustaining the skills for implementation of our healthcare workers. And then also the local barriers were fixed locally, just like we will see in a short while, the locally fabricated incinerator that was introduced in conjunction with the community, thereby fixing their local challenges. Then the use of the calibrated rates also become a routine in the healthcare facilities. So every woman to a single calibrated drip. And then quality issues were caught fast and then remedied, because there was a complaint about a leakage of some of the calibrated drips, I think in Kenya and DRC, which were quickly identified, and then the products were refined for scale up. So this is one of the testimony from a healthcare worker from Ondo State, Nigeria, which, and I quote, he said, "Since we started using the calibrated drip, we are no longer guessing. We now know the actual blood loss." So just a quick one about the thing on here. Sorry. So this is the locally fabricated incinerator that I started talking about, which is a low-cost community-built solution for safe disposal of the blood-stained calibrated drips, because it became a challenge on how to dispose of the blood-soaked calibrated drugs, because most of the rural primary healthcare centers lack working incinerators. So these calibrated, locally fabricated incinerators were introduced by the community themselves for the safe disposal of the calibrated grades. So as you can see in the picture, it was made from clay or mud at the cost of about $150 US. And then it was still built in 6 primary healthcare centers, 5 in Kebbi State and 1 in Ondo State, Nigeria. So this also leads to infection prevention and control management, and then also the healthcare facilities and the healthcare workers were taken through the training on infection prevention and control at their health facility, thereby improving IPC measures. So the calibrated risk metrics for 2025 and 2026, we have seen that 92% of vaginal births were used during using the drips, that's in the 6 countries combined, and then 72,951 births with blood loss objectively measured. And then almost 100%, that's 99% postpartum hemorrhage cases were treated with the clinical bundle within the 6 participating states, countries. And then how about the procurement and supply chain milestone? We have for Nigeria have procured about 50,000 drips, while India 40,050 drips were procured, while in the DRC 13,000, 379 drips were procured for scale up. So what are the key takeaways? So we want to make measurements objective. So moving away from the guesswork of postpartum hemorrhage estimation. And then also we have to choose the right product for your setting. So try to match your delivery bed type, and weigh also the biodegradable options, again, the safe life, and also every woman should have a drip at delivery. Of course, try to build skill that lasts through the midwife-led practice and the low dose high frequency, which has also been hammered from the initial onset, not just a one-off workshop. And then also don't negotiate on the quality. So quality issues are caught fast and promptly sorted out. Then the process should be embedded in the system. The Ministry of Health ownership and community solutions like the locally fabricated incinerator to sustain and scale up results for sustainability purpose. Thank you for listening, and back to Eva.
Thank you so much, Dr. Nura. We learned a tremendous amount about the introduction of calibrated drapes for objective measurement of blood loss during the project, and you highlighted some of those learnings. This is an incredibly dynamic space, and I think over the very near future, we're going to learn even more about how to improve on this. And you gave us one exciting innovation around an alternative to usual waste management of drapes, and I think a lot more will be coming very soon. So thank you so much. This is definitely a space to watch. Before I move on, this is a reminder to all of our participants. Thank you again for joining. If you have questions, please put them in the Q&A box that should be on the bottom of your screen. If it's not there, if you don't see a little Q&A icon, you should see a more box. Click the more box with the 3 dots, and then you'll see the Q&A icon. Click on that, and then it will give you a little box to put your question in. So please do populate the Q&A with your questions. If your question is for a specific person, please name that person. Thanks. I lost my ability to advance. There we go. Okay. All right. Okay, with that, I'm pleased to introduce our next speaker, Mr. Michael Muthamia. Mike works with Japaigo, Kenya as a Senior Regional Technical Advisor and Country Program Manager for the AMPLI-PPHI project. He is a nurse midwife with over 18 years of experience in implementing reproductive health programs across the public and private sectors. His main responsibility has been providing technical guidance in the design, implementation, and monitoring of RMN-CAH interventions and driving national scale-up in low-resource settings. In the last 6 years, Mike has dedicated his efforts towards translating recent WHO guidelines in postpartum hemorrhage prevention and management into practice under the Smiles for Mothers and the AMPLI-PPHI projects across multiple countries. He'll speak with us today on the motive bundle across contexts. implementation approaches, key learnings, and recommendations. Mike, over to you.
Yeah, so thank you very much, Eva, for the opportunity to share. We've heard about prevention and detecting of excessive bleeding after birth objectively. And as Eva mentioned, I'll focus on our experience around the motive bundle. So after diagnosis of PPH, using objective blood loss measurement, coupled by any abnormal hemodynamic danger sign, we need to administer the bundle within the shortest time and within 15 minutes. So the bundle comprises of massage of the uterus, oxytocic drugs, tranexamic acid, IV fluids, and then we examine and escalate care on a need basis. The emotive trial demonstrated that this intervention was associated with a 60% reduction in severe bleeding. That is groundbreaking, right? So AMPLI-PPHI tested this intervention in terms of feasibility and acceptability across different contexts and different levels of care in 6 countries. So in the next slides, I'll share with you our experience. So for us to introduce this intervention, a comprehensive intervention package was key. We started with training focused on multi-cadre. There's no single cadre that can address the issue of PPH. Facility-based training approach was key. Gone are the days where we take providers to hotels, and our focus was skill saturation. 1 or 2 providers may not bring change, but when we achieve saturation, there's a difference. Again, we provided models at the facility to support simulation and peer practice, which is very key. Emergency drills are also very important because emergencies don't announce when they're coming. We also worked with professional associations to create awareness among healthcare providers through job aids and also through knowledge sharing platforms such as webinars and congresses. We also engaged the community as the consumers of this intervention. For example, in India, we had ushers, we had community influencers in other countries who gave targeted education to women and their families. Quality improvement is also key. That really helped us to drive the intervention in the right way. We also use data to drive the intervention, addressing any gaps in implementation. Advocacy was also very important, and professional associations collaborated with us, FIGO and other professional associations, and we engage stakeholders to make sure that this policy change and we drive sustainability. So together, these pillars created a holistic approach to introduce the bundle across different settings. Yeah, so as we introduced the bundle, a key challenge was capturing the data. This was a new intervention and we needed to be innovative to capture data. So we modified our data capturing tools, the ones that are used by the government, to stamp the registers and add additional indicators and be able to see the progress. We also made sure that we collect supplementary data, making sure that we're able to capture all the indicators that we needed for us to monitor progress. In addition to stamping the registers, we provided wall charts where key indicators were displayed at facility level so that each and every facility could see how they're doing. So to ensure sustainability, we advocated with the national health management information systems across different countries to include additional indicators. And overall, this approach enabled us to effectively track the bundle utilization while supporting adaptive learning. So what did we see in terms of the implementation? There was high utilization of the motive bundle across different countries, ranging from 97% to 100%, which is really a near universal uptick. We also looked at the acceptability using the study data using the OADRI scores that we were assessing between a scale of 1 to 5, and the acceptability was 4.5 and above out of 5. So that really shows a very huge acceptability of this intervention across different contexts. So as we advocated for increased utilization of tranexamic acid as part of the bundle, we were cognizant that tranexamic acid, which is a life-saving molecule, can mistakenly be administered during spinal anesthesia, leading to catastrophic outcomes. From evidence, looking at data from 2018 and backwards, 21 reported cases led to severe complications and a 50% death. So this is an issue that we had to look at very keenly to avoid the confusion between tranexamic acid and bupivacaine. And therefore, as we scale up tranexamic acid for PPH treatment, we need to avoid these errors so that we ensure that there are safeguards. And there are clear measures that can be implemented, such as post-marketing surveillance for high-risk medicines, requiring that manufacturers modify their packaging, and also making sure that the procurement agencies differentiate these products when procuring. So the key message is simple. Please, in every facility, review your systems and determine how you can avoid this error. So I'll proceed now to share our recommendations, categorized into two: one, capacity strengthening and service delivery. So based on our implementation experience, we have some key recommendations on capacity strengthening. First, focus on saturation of skills through facility-based mentorship, where you train teams, ensuring that healthcare providers are supported not only with skills but also with job aids to reference how to administer the bundle. As I mentioned earlier, it's important to use a multidisciplinary team approach to training so that you have champions across different cadres and things will move. When you introduce something new, you usually get resistance. We got resistance with introduction of the bundle, but when you have champions across different cadres, acceptability increases within no time. And then third, we need to ensure that we have routine peer practice, so availing models, especially mama natalies, and having dedicated skills practice corners is really helpful to standardize care. We also recommend making sure that we have regular emergency drills so that the teams can be prepared all the time. Protocols are important. We need to make sure that we avail them on the walls so that the care is standardized. And finally, on capacity strengthening, we created virtual platforms to enable coordination, mentorship, and sharing of experiences across different teams, not only among clinicians, but also among commodity managers and data managers. And together, these approaches ensure that we have sustained skills, improved teamwork, consistent and high-quality care in administering the bundle. Moving on to service delivery. For us to effectively administer the bundle, we need to make sure that we institutionalize teamwork and task sharing. We need everyone, including the support staff, so that all providers understand their roles. We also need to ensure that we have consistent availability of medicines, especially tranexamic acid at the point of care, and ensuring that midwives have the authority to use these products without prescription. In some contexts, these products are kept in the pharmacy, so by the time you go rush and get, it's already late, too late. So we need to make sure that they are at the point of care and midwives are empowered to use them. We also need to ensure that we track appropriate use, especially of tranexamic acid, making sure that it's only used for treatment. In some scenarios, there's a potential to give tranexamic acid to all mothers, which is not right. It's only for PPH treatment. And then we need to quantify appropriately, because the tranexamic acid that we use for PPH treatment is also used for trauma. And therefore, we need to make sure that we quantify correctly so that the tranexamic acid that is supposed to be used in maternity is not taken to the outpatient. We also need to ensure that we're doing audit and feedback and having dashboard to track our progress over time. Again, having a fully stocked emergency kit and crash cards is key, especially when emergencies happen. And as I close, I'd like to mention this quote from Zambia, which says, "We used to have a lot of referrals for patients who would go into shock and would need ICU, but with the introduction of drips and the bundle, that has lessened. We still see PPH cases, but the response is so quick, and now we rarely have referrals." A powerful story from Zambia, a quote that shows that with speed and effective response, we can reduce referrals and improve the outcome of our mothers. So with better measurement of blood, using calibrated drips and rapid use of the bundle, we can improve quality of PPH management and ultimately have fewer complications and reduce need for referral to higher facilities, leading to better outcome for our mothers and their newborns. So thank you. Back to you, Eva.
Thank you so much, Mike. That was terrific. I think there is so much excitement about the Motive bundle, and there is a temptation to say, this is easy. You're very familiar, most of us who work in obstetrics or on maternity wards, with all of these steps. The only addition is the TXA. But it's not easy. It is not easy to garner provider behavior change. I think that's one of the very hardest things. We're very stuck in our ways. And so when something new is introduced, even though there's a lot of familiarity, providing this treatment as a bundled package and not in sequence without waiting between steps has been really hard. And you acknowledged that we had to embrace the resistance and we had to rely on champions. We had to rely on continued peer practice in order to overcome that. I think we tried to do that very well with the project, and you showed some of the data where we did do that. People won't change because we say you should change. People will change when they believe that that change is worth it and will make a difference. And I think through those elements and those recommendations that you pointed out, Mike, we were able to do that. So thank you for articulating that so beautifully well. I'm really pleased to introduce our next speaker, Dr. Chirag Bola. Chirag is the country program manager for AMPLI-PPHI India and the national program officer and state head in Gujarat for JPIGO, where he leads field implementation and operations of maternal health programs in MP, Maharashtra, and Gujarat. He has nearly 15 years of experience in program management, monitoring, and innovation in public health thematic areas, leading digital health interventions, surveillance, and immunization in various states in India. He'll present today on reaching every birth with a targeted approach, advanced distribution of misoprostol for self-administration to prevent postpartum hemorrhage. Chirag, over to you.
Thank you, Eva, for introduction and for this opportunity. Good morning, good afternoon, and good evening, everyone. Today I'm focused on one critical but often overlooked area of the postpartum hemorrhage prevention, and that is not every woman deliver into the facility or in the presence of the skilled provider, so that the prevention of the PPH can be taken care for the every delivery. So if we want to prevent the PPH and save the mother from the preventable PPH death, we need to think beyond the facility walls. And we need the strategy that work beyond the facility interventions. And today I'm going to share about the AMPLI-PPHI experience on the advanced distribution of misoprostol for self-administration, or I would say ADMSA, as a harm reduction strategy and how that worked during the AMPLI-PPHI intervention. This slide reminds us why we need the alternate strategy beyond the facility for the PPH prevention. Even after huge progress in the maternal health portfolio globally, nearly 1/3 of the women delivered outside of the facility, either home or in transit, in the LMICs, and this is a huge proportion. These women are at the disproportionately higher risk of the preventable PPH death, and these are usually the women who are living in the poor and underserved area. So while we continue to promote the facility delivery and the stillbirth attendance, we must also acknowledge that the reality of that some women will not reach to the facility for the safe delivery. And this is what we call the system inequality. And we need to focus, we need to have the strategy to address the systemic inequalities. And here where the ADMSA is come. ADMSA, that is advanced distribution of the misoprostol, is given to the woman during the antenatal period for the self-administration immediately after childbirth if delivery occurs outside of the health facility and no stillbirth attendant is present at that time. And the question is why? So most of the time, the outside of the facility, the oxytocin is not the practical option because it requires the cold chain, it requires the injection, it requires the skilled staff. And here comes the misoprostol, which is rather a very feasible option for the prevention of the PPH in case of the such deliveries that happens outside of the facility. Most importantly, WHO also recommended the advanced distribution of the misoprostol only in those settings where the birth occurs outside of the facility and the skilled personnels are absent, and with the targeted monitoring and the evaluation. These are specifically in the remote, poor, and hard to reach area or the underserved area. This is a harm reduction strategy and not the substitute of the institutional delivery. So, how the AMPLI-PPHI had implemented across the countries. So here the context of the different countries are really matters. We had implemented the advanced distribution of misoprostol in 4 countries, and every countries are different. The contexts are different in terms of the proportionate home birth, in terms of the approved policy for the misoprostol advanced distribution, in terms of the health cadre that are community service level. So community level service provisions are available, how they are trained for the advanced distribution of the misoprostol, and most importantly, certain challenges with the reference to the community service provider belief of increasing the home birth. They might be used for the abortions. So that are inherent challenges were also there. So the context of the every country are different, and we try to adopt the strategies that suits to the every different context. And that strategies are focused on the 3 things. One is identification of the eligible pregnant woman for the misoprostol distribution. And this identification is done based on the WHO recommendation for the screening of the woman for possibility of home birth. This screening had been done at the various level, at the facility level or the community level by the healthcare service provider, depends on the country context. The second critical step was the distribution of the tablet misoprostol. And that distribution was done by the healthcare service provider or the community health worker at the facility or at the community level with the proper counseling of the woman and at the right time of the gestational age. The distribution time was the critical one, and the distribution was done during 32 to 36 weeks of the gestational age. And the most important is the following up and the monitoring. So most of the cases, we had done follow-up with the distribution mother after 1 week of the distribution and immediately after the delivery within 24 hours, so that we identify that the correct use of the misoprostol has been done, and that we can assure that there was no any side effect. This strategy was supported by the update in the existing registers and the supplementary registers for proper data recording and the reporting mechanism so that we can track end to end from provision to the usage of the misoprostol, and the capacity building of all healthcare service provider has been done to ensure that this should be done, the misoprostol should be appropriately used during the implementation duration. What we actually get out of this intervention, that we had identified 5,600 eligible mothers for the misoprostol distribution, and among them 5,063 women were given the misoprostol for the PPH prevention in case of the birth outside of the facility. Among them, 2,350 women who actually delivered outside of the health facility, and more than 95% of them confirmed the use of misoprostol correctly. And this is really the exciting one. If we rightly identify the eligible woman, if we counsel appropriately, and if we distribute the misoprostol at the right time, the misoprostol does not only act for the prevention of the PPH, but it is also promoting few institutional birth. I'll give you the example with the data of the two countries. So in Kenya and the DRC, the number of women who has been identified for the misoprostol distribution and who have been given the misoprostol, majority of them have delivered into the facility. Only few has delivered into the community or the outside of the facility, and more than 90% of them have consumed the misoprostol at right time. This results indicates that the fear of advanced distribution of misoprostol for promoting the home birth is not actually worked on ground with the proper intervention strategy. And move to the next slide. Yeah. So overall healthcare provider experience is positive with the feasibility and the acceptability of the misoprostol. Across all the countries, the provider said positive feedback on the feasibility and the acceptability. Specifically, their inputs were on the integration into the routine practice, integration into the antenatal care routine services in the identified geographical area where the advanced distribution misoprostol is needed, or say eligible pregnant woman for the misoprostol distribution is there. So this slide gives the mixed picture of AMPLI-PPHI intervention, things that has worked well and the things that needs the attention. We experienced that the community accepted the misoprostol very well across all the 4 countries. The strategies that we had implemented across the 4 countries and the platforms that we had implemented for the advanced distribution of misoprostol are feasible and are acceptable. It did not increase the home birth or promoted the institutional delivery through the adequate counseling, and did not report any misuse as a abortifacient. But at the same time, few challenges that needs the active attention, and these are the forecasting and the stock out of the misoprostol, specifically the policy guideline or the program that is system that is supporting the advanced distribution, end-to-end tracking of the correct usage through the robust documentation, cultural norms of the community, and the supervision and the hand-holding support to the healthcare service provider. So our key learnings and the strategic insight was the major one is the advanced distribution of misoprostol is a complementary, and it is not the replacement of the institutional delivery or the delivery by the skilled provider. The first is it is a feasible and diverse low resource setting, the scalable implementation for the woman likely to deliver at home. Community platforms are key for the last mile reach because it is the outreach and the woman we got to connect at the community platform. Timing really matters. the distribution in the gestational age of 32 to 36 weeks ensure that the woman, when delivered, should have the ready medicines in hand before the labor, and they are counseled for the correct use immediately after birth. Strong monitoring is essential with the key of correct use of the misoprostol, and integration into the existing maternal and the community health system is generally more suitable than the vertical approach, and it is also suggested by the service provider during the program implementation. So what does it means for the global public health professionals? So when we say the policy, it should be the formal endorsed ADMSA policy within the National Maternal Health Guideline for the context-specific strategy. For the system, there should be a community health worker capacity building, supervision, and the supply chain to ensure the timely distribution. There should be a adequate program that is the standardized third trimester counseling and the dosage instruction, birth preparedness messaging, and the post-distribution follow-up. And we should continue to generate more and more learnings on the long-term impact for the scale-up models of the ADMSA. So let me conclude this section with the key message that if we want to reach every birth, we need strategies that are both evidence-based and reality-based. Advanced distribution of misoprostol is one such strategy, carefully targeted, strongly monitored, and firmly positioned as a complement to the stillbirth attendant and not the substitute to it. I'll rest here. I'll hand over to Eva. Thank you.
Thank you so much, Chirag. This is a wonderful presentation and a wonderful topic, and you really demonstrated for us the key findings among many. Two are that we did not find a pattern of misuse, and we did not find that this contextualized, targeted approach to advanced distribution of misoprostol for self-administration led to a decrease in facility births, in fact, the opposite. And that is really well grounded in a decade of evidence showing the same. And so I think that we were able to take that to real implementation and have those same findings gave us great confidence that this targeted approach is extraordinarily valuable. Thank you so much, Chirag. And last, but most certainly not least, I'm pleased to introduce Ms. Rosemary Njogu. Rosemary is a registered nurse midwife with over 16 years of experience and a master's degree in community health and development. She's a senior regional clinical advisor at JPIGO, leading immunization, nursing, and midwifery initiatives across Africa. Her work spans HIV, RMNCH, and maternal vaccines with contributions to research. A 2024 Women Lift Health Fellow and a DAISY Award recipient, she is also passionate about mentoring young women leaders. Rosemary will put all of this together that we've heard this morning already through her presentation, Beyond the Guidelines, Creating the Enabling Environment for Life-Saving Postpartum Hemorrhage Care. Over to you, Rosemary.
Thank you. Thank you so much, Eva. And good morning, good afternoon, and good evening. I'm happy today to continue with this important discussion we've had about the preventing, detecting, and treating PPH, which requires a strong enabling environment that supports healthcare providers to perform effectively and be able to translate guidelines into practice with the right system, skills, and coordination in place. As we've heard from the previous presenters, they've mentioned much about the Ministry of Health. And in this project, Ministry of Health support was a backbone for successful intervention delivery and overall project implementation. Through continuous engagements, the project strengthened and institutionalized clear postpartum hemorrhage referral pathways where in lower level facilities, where need be, they were able to refer to higher level facilities for PPH complication. This contributed to timely life-saving care for women with PPH who required escalation of care. In addition, standardized operation procedures which were developed and disseminated. Someone moved my slide. Okay. Were developed and disseminated across all facilities, ensuring consistent and coordinated approaches to PPH management. To enhance drug quantification and supply chain efficiency, the project provided mentorship on supply chain management from the national to facility level. It drew on Ministry of Health expertise and distribution systems for project procurement for drugs and calibrated rates, while strengthening the capacity of healthcare workers across all facilities in labor ward theaters and on commodity management, and being able to maintain the reporting systems across from the lower level to the higher levels. The project also improved the drug quantifications and consumption, reporting, and monitoring systems. A feedback mechanism from the facility to MOH and project staff on drug and calibrated rate was also put in place for timely commodity support when required, including use of technologies, especially WhatsApp was widely used across all the levels and at facility level to make sure that feedback mechanisms were in place. So to strengthen the system and at facility level, and this has been mentioned widely by the previous presenters, the healthcare providers were trained on the use of essential drugs, such as eat-table-captocin for prevention and TXA as part of the PPH treatment bundle. The use of low-dose, high-frequency approaches, then this was cascaded from the higher level to the lower level facilities, and a tracking system was put in place. There was largely use of a multi-kanda approach, starting from the midwives, who are the first responders of PPH, which strengthened teamwork and inclusivity in managing PPH complication. Across the 6 countries, over 4,000 healthcare providers were reached. Project standard findings showed improved provider confidence in managing PPH and greater team efficiency, contributing to better maternal outcomes. Over time, documentation system was strengthened to improve tracking of patients. For example, we had maternal perinatal death surveillance and response and continuum of care approaches to monitor, review, and follow up on patient outcomes. Data dashboards were used across all countries to assess performance and provide timely feedback to the Ministry of Health. Monthly meetings further strengthened data ownership at facility level. Data was actively used to identify gaps and deviations, enabling timely correction and corrective actions, including development of case reporting tools to be able to track the outcomes after use of the drugs. In addition, they held post and reflect learning sessions at facility level and also involving the managers to improve monitoring and patient outcomes. Over time, after training, the social and behavior change materials were developed to be able to support the ongoing trainings and the ongoing scope at facility level. And this was done more in labor ward and theaters, ensuring that job aids were put in place. And the tools also were developed, summarizing key preventive interventions, the medication dosages, and also showing step by step on how treatment should be offered. More so, also looking into calibrated drapes, disinfection, and infection prevention procedures. They also outlined complication management, including when to act and when to escalate. These practical, easy to use job aids were the game changer in improving practical use at facility level. So, and there are things today we need to, all of us, look into them and do together as we continue to look into how can we translate the guidelines or the policies to practice at facility level. We require all providers to be equipped with knowledge and skills that is effective for effective management of PPH. We must also ensure the essential commodities are available, and beyond this, we need to create a sustained enabling environment that supports timely detection, management, and escalation of PPH. And thank you, and back to you, Eva.
Thank you so much, Rosemary. That was terrific. There's no way to do all the other pieces without having this enabling environment as you've shown us. All right, I think we get to the Q&A session now. Finally, all you patient people. Let me advance my slide. Oops. I actually can't advance my slide now. Can we share again? If we can share the slides again, that would be great. In the meantime, I'll start asking questions. Great. Okay. Thank you so much. And then we've got everybody on camera. That's great. There are lots of questions in the chat. Thanks everybody who put those in. We won't be able to get to all of them, but let's get to a few. Let me start with Chukwefu. Giving you a lead in here. Hold on one second. Let me find it. It was a great question. Okay. So Chukwefu, this one comes to you from one of our participants. Has there been any strategy, guidance, will from governments to take a targeted approach to heat-stable carbetocin introduction, focusing on facility levels or parts of the health system where the risk of poor oxytocin quality is highest? Big question, really important question. Over to you, Chukwefu.
Sure, thank you, Eva. And it is truly a great question. And it's nice to see how people are looking at how countries can scale up heat-stable carbetocin in the various countries. But this question also highlights the need to consider country context, as it's not a one-size-fits-all. And so this is where we emphasize co-creating the strategy and the guidance with all stakeholders at all levels. We have seen countries like Zambia and Kenya where the government intends to replace oxytocin at all facilities for prevention of postpartum hemorrhage and maintain oxytocin for other indications. But there are other countries like India that have a more targeted approach. And of course, depending on the guidelines and the policies that are currently in place. So it's really a tailored approach in different countries. I hope that answers your question. Thanks.
Thanks, Chukwefu. I think that's really important. There are a lot of questions about drapes, no surprise. And I'm going to pose this first one to Dr. Noura based on your presentation. People are really interested in the locally made incinerator. So this person's asking if you could speak to how the incinerator works practically. For example, how many drapes can it contain? What happens when it's full? All those pieces. Anything you could provide would be helpful. Over to you, Dr. Noura.
Okay, thank you very much for the question. The locally fabricated incinerator, just like I've said, is an innovation, a community-led innovation in order to tackle the challenges of safe disposal of the calibrated drifts. So the the incinerators are made out of clay, and then with some metal doors for injection of the waste. So it's actually depends on the size of the locally fabricated incinerator. There are two sizes, the small size, and then there's a bigger size. Just like in the context, we have done an SOP, and then we have also validated the SOP for the design and then for the management of the waste so generated from the calibrated drift. So the number of drifts that can be safely burnt or disposed of depends on the size of the incinerator. There's a smaller one using, I think, is it 1,000 blocks, and another one using 1,500 blocks. So it all depends on the size of the drift. And then when there is fill up or it is overfilled, we have already consulted the officers from the Environmental Health Department of the Ministry of Health, which will now come and inspect the waste, and then will now treat the waste before it is finally cleared up from the incinerator and then disposed of. Because they told us that sometimes there could be, they can even manage it and then use it for agricultural purposes, using their chemicals after the monitor and see. So that is the way it is disposed of the waste. And then, of course, the number of drifts disposed of depends on the size of the incinerator. Thank you. I hope that answers part of your question.
Thank you so much, Dr. Noor. I think there's a lot of interest in the locally made-ness of this incinerator. As you know, and many of you probably on the line, this was showcased at the IMNHC conference in Nairobi in March, and there was a tremendous amount of interest. So I think we're going to keep learning from this one. Thank you so much. All right, let's see. There are a lot of drape questions, but you are off the hook, Dr. Noura. I'm actually going to give this to you, Rosemary, and that is about challenges we faced with the drapes. And this goes a little bit to your enabling environment type of presentation around behavior change. The question is, this is for Rosemary. According to your experience, what were the main challenges during the use of the calibrated drape? Rosemary, over to you.
Thank you. Thank you so much, Eva. We continue to face very many questions, and this is because the calibrated drapes, it's new, and the healthcare workers have realized it's working well to ensure that they do timely intervention as pertains to treatment. So some of the challenges, and I will also say that we were able to navigate these challenges, started by trying to use a single-use drape with reusable mats. So we had challenges in some countries like Zambia, where healthcare workers were fearing issues to do with contamination as when they were processing the mats. And so they feared matters to do with contamination, maybe with hepatitis B. We went in and advocated for hepatitis B jab. They also feared that they will not be able to process the mats all this time. So there was so much back and forth, and we got to a place where we switched then to biodegradable drapes in Zambia. And I'll still give the case of Zambia because I want to follow that case through. We also got a challenge of the drapes leaking because the biodegradable drape was new. The manufacturer was still testing. So we got them reeking. We got to give feedback to the manufacturer. We got to get the manufacturer upgrade, and we're now stable with that. However, in Nigeria, we got the straps for tying around the woman was slightly shorter when we started the drape work. And this, we also gave the feedback to the manufacturer, and that was corrected as time by. What I want to mention is challenges are there as we introduce the drapes, because also the disposal issue, and that's where we came with the locally fabricated incinerator in KB. Issues to do with also other areas where incineration is wanting, that they don't have a medical incinerator. They also faced challenges. But do not get scared. We are able to navigate this when we have good synergy and discussion with the ministry on how to navigate it safely. Two things to leave you with: safety for the healthcare worker and better intervention for the client. We need to balance this as we apply the drip. Thank you, and back to you, Eva.
Thank you so much, Rosemary. There are many, many questions in the chat. We won't get to all of them. A few we will answer in the Q&A, specifically some questions around potential misuse of misoprostol, potential for our misoprostol approach to decrease facility births, and we can answer those in the Q&A. So I'll give Chirag the opportunity to write that to you. But our last question, because we are quickly running out of time, will go to Mike, specifically about the motive bundle. And this is a broad one, so you'll have to pick a few. What are some of the challenges that you saw facilities and providers face while implementing the motive bundle? And what are some of the ways that we can overcome these? Over to you, Mike, and this is the last question.
Yeah, so thank you very much, Eva. So one of the challenges that we saw was that with the introduction of its stable carbetocin, health facilities were quite comfortable, and we needed to track the availability of oxytocin so that it can be available for treatment. So these need to really carefully look at the stocks of oxytocin, even as we provide carbetocin as the first line. So making sure that that product is available. Yeah, so the other issue is around that initial delay. Initially, when the bundle was introduced, there are challenges sometimes with the new intervention. So there's a way of doing things in certain facilities. So we had to overcome that initial resistance in some countries, especially by involving senior members of the team, making sure that obstetricians are involved, making sure that midwives are involved, so that they agree that this is a standard of care. So I think those are the few, challenges that I can highlight for now. But essentially, as you saw from the numbers, the bundle was widely acceptable across different settings. And it's something that you can do with the health workforce that you have there. You don't have to hire additional providers for you to implement the bundle. Over and back to you.
Thanks a lot, Mike. It takes practice, right? It takes practice, and it takes iterating and being flexible and understanding that it takes time to bring about change. Wonderful. Sadly, we have come to the end of our Q&A. I know we have many more, and we'll continue to answer some of them in the chat, but we've reached the end of our time. Thank you, all of you who have submitted questions, and those of you who have answered. With that, we'll move to closing remarks from Dr. Jeffrey Smith. Dr. Jeff is the Senior Technical Manager of the Strategy Team at Unitate in Geneva, Switzerland, where he leads the maternal newborn health portfolio and engages internally and externally with partners to increase access to quality maternal newborn health products. He is also co-chair of the UN Health Products Working Group and promotes global and national collaboration for improved product access. He's an obstetrician gynecologist and global health strategist with 30 years of experience in maternal newborn health across Africa, Asia, and Latin America. With that, Jeff, please offer your closing remarks.
Great. Thanks very much, Ava. And this has been a fantastic webinar. I first want to thank the AMPLI-PPHI team and all of the government partners and all of the partners for the incredible hard work. We know that implementation is hard. We know that implementation is far too slow. We taking evidence and guidelines to practice is a difficult task, but the only way we achieve it is having a careful plan and experience. And I think this team really demonstrated that today. It was really important to hear authentic experience from these implementation experts. And I think every one of the speakers addressed one of the unique things about the AMPLI-PPHI program, which was the fact that AMPLI-PPHI worked on both supply and demand for these interventions at the same time. And so I want a couple remarks on each of the speakers about that. This project spanned the horizon from prevention to diagnosis to treatment. And in each one of those domains, really looked at the supply side and the demand side together. Chikwefu from Zambia really spoke about introduction of HSC through a smart stepwise approach, but he highlighted champions who are building demand, especially building clinical demand among midwives and providers. But he also talked about overcoming the systemic barriers to implementation, meaning making sure that there was training, making sure that the policy and the guidelines were updated, and ensuring consistent availability. Dr. Nora from Nigeria talked about the introduction of the drapes, but he also talked about supply and demand. It was a government-led initiative. There had to be political will in order to both tackle postpartum hemorrhage and overcome the barriers that would be found along the way. He talked about the nimble response, and that nimble response, that ability to solve problems as you go, comes from being able to look at the equation of supply and demand as you move forward. Mike, one of our great champions from Kenya, talked about the bundle, and he spoke not only about the what of the bundle, but the how of the bundle. Too frequently, we talk just about what the MOTIVE stands for, but we also have to talk about the implementation approach, the importance of advocacy, champions, preparedness, low dose, high frequency training, audit and feedback, because in order to do good advocacy, you need good data. And that idea of audit and feedback and being able to continue to improve your performance really made a difference. Chirag, I want to thank you for being on the front lines of an intervention, advanced distribution of misoprostol, that we've been talking about for 25 years. As I said, it takes a little while in this community to implement some of these interventions. We've been talking about advanced distribution of misoprostol for 25 years. The data that you showed was critical. 95% of the women who were provided the drug and delivered at home took it. The people I want to convince are the women, and those women clearly were convinced of the importance and the safety and the value of this intervention. That's the measure of success. 95% of women who delivered at home and had the medication took it. And finally, Rosemary, you'd always do such a nice job of pulling things together. Looking at the enabling environment, again, supply and demand. We need MOH leadership, but that has to come with supply chain support, making sure the products are available, developing training approaches, and making sure that all of these things are working in concert. So thank you for the opportunity to not only listen in to this incredible series of presentations, but also to comment on it. I think all of you have done a wonderful job because from the beginning, you have thought about that balance of supply and demand. You have found solutions and you have achieved success in this program. Thanks, and back over to you, Eva.
Thank you so much, Jeff. Thank you for taking the time, for being with us this morning, for listening, and then for providing these reflections and insights. They're so important for us all to hear because we've been so heads down. So from a person who's been involved with us from the beginning, but has also been a step back from the development of these details is really helpful. Thank you again to all of our presenters. You did such a wonderful job. I know what it takes to put a webinar like this together. You all did terrific. And thank you, all of you who joined this webinar and who will continue, ideally, to join our series. Be sure to do so. We are just at number 2. We've got 2 more. So be sure to tune into those other webinars in the series across June. A registration link is here that will be, is it here? Can they click on that? If not, we'll post the registration in the chat, and it will also be emailed to you after the webinar. You can also access via the registration page and the QR code. The webinar and the previous webinar in AMPLI-PPHI's learning series has been recorded and will be made available on AMPLI-PPHI's online repository of key project resources and tools, which can be accessed via the link provided in the chat and in your post-webinar email. And we'll also take this opportunity to promote once again the AMPLI-PPHI supplement in the International Journal of Gynecology and Obstetrics. Be sure to explore the supplement by using the QR code on the screen or selecting the link in the chat. Again, thank you everybody for joining. We look forward to seeing you at another AMPLI-PPHI webinar soon. Have a good day all.